Hello everyone, am I live? Give me a minute to confirm if I'm live. I will start the session ahead. A very good morning, Sachin, Swanand, Osama. Are you people there? Am I live? Can you see me? Can you hear me? Can you give me a thumbs up in the chat box if you can see me clearly? Give me a minute to confirm. I'm not able to see whether I'm live or not. Yes, I hope it's working now. Okay, great. So I welcome you all for today's session. A very good morning to all of you. So today I am going to teach you a very important topic, that is insulin in pharmacology, in systemic pharmacology, in endocrine pharmacology you must say. So yesterday we have completed, or we have started and seen the classification and mechanism of action of few important drugs of oral hypoglycemic agents, and now it's time to study about the insulin, right? So today I am going to teach you all about the insulin, how many types of preparations are available, what are the various types of regimens, what are the types of the insulin, what is the mechanism of action, how does it work, everything about insulin. You got my point? So without wasting any further time, let me continue with the insulin. So before starting insulin, let me give you an overview about I am going to talk about the artificial insulin, which we give as a treatment in diabetic patients, especially type 1 diabetes. In type 1 diabetes, only treatment is insulin. But in type 2, we will first try with oral hypoglycemic agents. If not controlled, at last we will switch to insulin, right? So we are going to talk about the artificial insulin preparations available in the market today. But before that, before studying the artificial insulin, we should be able to understand the natural physiological insulin which is secreted by pancreas of human. So before starting the artificial preparations, let me tell you the natural insulin a little bit. A 5 to 10 minutes talk about the natural insulin, so it will be easy for you to understand the artificial preparations, the various types of preparations available in the market for the insulin. So we know human have a intra-abdominal organ which is known as pancreas. So I guess here you can see a human body. Inside the human body you can appreciate this is pancreas. Although pancreas is anatomically a single organ, but histologically and functionally it is a dual organ. It is having two portions, the exocrine part and the endocrine part. The exocrine part secrete the enzymes. The enzymes help for digestion, and the endocrine part secrete the hormones in the blood, the various types of hormones which are regulating various mechanisms, right? So we can see the pancreas, it is a dual organ, as I have told you, the exocrine and endocrine, secreting hormones and enzymes and hormones respectively. So you can see this is pancreas here, and if you can see the histopathology of pancreas, this is the histopathological diagram of the pancreas, inside which I can see two things. Number one, can you see these circles? What are these circles? These are glands. These are known as pancreatic acini. This is the exocrine part, and this acini secrete the enzymes. Today I am not going to teach you the exocrine part, that is the enzymes, the digestive enzymes. So basically the digestive enzymes are secreted by pancreatic acini. I am more concerned with the endocrine portion of the pancreas today. So endocrine portion of the pancreas, here you can see in the center, it is known as collection of 5 type of cells. It is known as islet of Langerhans. Islet of Langerhans is the microscopic collection of 4 type of cells. So here basically 4 major and 2 minor cells are there. The cells are grouped together and it is known as islet of Langerhans. So what are the 4 major cells? The 4 major cells are in front of you: alpha cell, beta cell, delta cell and PP cell. What is PP? Pancreatic polypeptide. So alpha cell secretes glucagon, beta cell secrete insulin. So today we are going to study insulin that is secreted by beta cell of pancreas. Delta cell secrete somatostatin, and pancreatic polypeptide cells secrete pancreatic polypeptide. Give me a thumbs up. You got it, Osama? Osama, you got it? Others, you got it? Osama, Swanand, everyone, Sachin. So shall I proceed? The 4 type of the cells. Now what happens in diabetes? So diabetes is a disorder in which the patient have hyperglycemia. What is hyperglycemia? More blood glucose. Why the glucose level will be raised? So diabetes is a disorder in which the blood glucose is high. The blood glucose is high. The disorder is known as diabetes. Now blood glucose is maintained by 2 hormones. Can you see a simplified diagram I have drawn for you? Can you all see this diagram? On one side I have drawn a blood vessel. On other side I have drawn a cell, right? Now I have drawn 2 hormones here, the insulin and the glucagon. So insulin is secreted by beta cell of pancreas, glucagon secreted by alpha cell of pancreas of the islet of Langerhans. Islet of Langerhans में 4 सेल होते हैं. There are 4 cells. So out of which one is alpha, one is beta. One is secreting glucagon, one is secreting insulin. You can see the arrows. The arrows here are important. Let's talk about insulin. See the arrow of insulin. It is taking, insulin is a hormone that take the glucose from blood to cell. See the arrow, and it store the glucose in the cell in the form of the glycogen. So insulin basically insulin decreases blood glucose level. Insulin decreases blood glucose level because it carries the glucose from blood to cell. On the contrary, glucagon does the opposite. So glucagon takes the glucose from the cell to the blood and increases blood glucose level. So humans have both of them. So whenever I eat my food, my blood glucose level rises. At that time, insulin comes in the blood and shows its action. Whenever I am fasting, I am not eating. At that time, my blood glucose level is low. I do not want to go in hypoglycemia. So the body will secrete glucagon and it will increase the blood glucose level. So at any moment, the basal blood glucose level is 70 milligram per deciliter, and it is maintained by these two hormones, insulin and glucagon, depending whether we are taking the meal or whether we are fasting. Everyone give me a thumbs up if you got this physiology. So I have explained you about the physiology of the insulin and glucagon. Now if you have understood it better, now it will be easy for you to understand the insulin, various type of preparations and its mechanism. So look at the arrow. Insulin carries the glucose from blood to cell. Now what are the cells? Basically 3 cells. The liver cell, the skeletal muscle cell and adipose tissue cell. So glucose is stored inside these 3 cells. These 3 are known as target organs. Give me a thumbs up. You got it? Everyone, jitne audience utne thumbs up. You got it or not got it? So this is the physiology in body, human body, in you, me, every healthy individual. These two hormones are there. So currently I am fasting. I have not eaten anything. So inside me, glucagon is working. But after the session, I will take my breakfast. At that time, in my blood, insulin will be secreted. So inside the pancreas, inside the islet cells of the pancreas, alpha and beta cells both are activated. So depending on the situation, which one is activated and which hormone will come in the blood, and they will maintain the homeostasis. This is known as homeostasis, right? So the same thing is written in front of you. Now you will say, ma'am, it is physiology, it is normal. But what happens in diabetes? Diabetes mein problem kya hai? So this is the problem in diabetes. See the same diagram. Diabetes mein this is the problem. The problem is with the insulin, not with glucagon. ठीक है? Problem is with the beta cell, not with alpha cell. ठीक है? What is the problem? There can be two problems. Either the insulin is absent. It is absent because the beta cells are destroyed and there is no insulin in the blood. Or it is present. It is present, but it is non-functional. It is non-functional. It cannot show its function. It is present, but it cannot take the glucose from blood to cell. It is also present. So the absence is known as quantitative defect and non-functionality is known as qualitative defect. So insulin can have two defects. Both can result in diabetes. So insulin is absent in type 1 diabetes and insulin is non-functional in type 2 diabetes. You got my point? So here you can understand the pathophysiology of two type of diabetes. The type 1 diabetes, beta cells are destroyed by autoimmunity. So no beta cell, no insulin. So basically type 1 diabetes is an autoimmune disorder in which insulin is absent, so it is quantitative defect of insulin. But in type 2 diabetes, beta cells are absolutely alright. They secrete the insulin in blood, but that insulin is non-functional. It cannot show its action. So whether it is present or not present, it hardly matters. So actually, it is a qualitative defect of the insulin. Give me a thumbs up everyone if you got it. Shall I proceed ahead? Shall I proceed? So that is about the insulin. So you can see the diabetes. So you will say, ma'am, then what is the problem? If insulin do not carry, either it is absent or non-functional, what will happen? It will not take the glucose from the blood to the cell. So two problems will happen to this individual. Number one, blood glucose rises. Can you see the arrow? Blood में glucose बढ़ जाएगा because it is insulin is not taking the glucose from the blood to the cell. And number two, cell में glucose कम हो जाएगा because of course the same reason, right? Now blood में glucose बढ़ना is hyperglycemia. If the blood glucose is more, it is hyperglycemia. You will say, ma'am, now whether my blood glucose you are saying normal is 70, whether it is 70 or 170 or 270, how does it matter? I don't check my blood glucose level daily. So how does I know कि inside me my blood glucose level is raised? And is it necessary to treat if I don't have any symptoms? Will it give some symptoms? Not acutely. Acutely कोई symptoms नहीं देगा. But chronically, if the blood glucose is raised, there is hyperglycemia, it will cause end organ damage to 3 organs in human body. It will cause kidney damage. It is known as diabetic nephropathy. It will cause retina damage in the eye. It is known as diabetic retinopathy. and it will cause damage to the nerves, the sensory nerves. It is known as diabetic nephropathy. So these are the 3 chronic complications of hyperglycemia. So in the blood, if the glucose is raised for years and years and patients are not taking treatment, you know, in India, many patients come to the clinic and they say, doctor, if I say them your blood glucose level is raised, you are diabetic, you should start treatment. They will tell, no doctor, I don't have any symptom. So whether my blood glucose level is raised or not raised, how does it matter to me? I don't have any symptom, I don't have any pain due to this. So, you know, patient ke liye pain is everything. If pain is there, some problem is there, then only the patient will take treatment. So you have to explain the patient that currently you don't have any symptom, but if you let the glucose level to be raised forever, for years, after 5-10 years, your kidneys will fail, your nerves will get damaged, and your retina of eye, you can blind, the retinopathy can be there. So these can be the complication. To prevent it, you should take the treatment, right? So this is like, you know, the increased blood glucose level in the blood. Now what about the glucose level decrease in the cell? On one hand, blood mein glucose zyada hai, usse what is the problem happening? We have seen. Now the cell glucose is less. What problem does it cause us? If the cell glucose is less, does it cause any problem? Yes. Basically the cells are starvation. The cells are in starvation. They are not getting energy. They are deprived of energy. They are not getting glucose. They are not getting ATP. So can I say the cells are deprived of energy in spite of having abundant glucose in the blood? ठीक है? हिंदी, do you understand हिंदी? जितने भी लोग हैं, हिंदी में कहावत है, समुंदर तले प्यासा, सुना है? या दिया तले अंधेरा, सुना है? Both proverbs are fitting best here. You know, समुंदर तले प्यासा means the cell is having abundant of glucose in the blood, but the only problem, cell cannot utilize it. You got my point? Still the cell is starving. दिया तले अंधेरा. So ये proverb यहाँ पे fit होता है. समझ में आया क्या? So that is the problem. So there are 2 types of diabetes. We have already discussed type 1, type 2. What is the problem in type 1? What is the problem in type 1? Okay, type 1 is known as juvenile onset diabetes because it is present since birth. Birth से ही the beta cells will be destroyed, but it will present in adolescent age. So mostly the diagnosis is done at 10 to 15 or 10 to 20 years of age में diagnosis होता है, right? So that is juvenile age. That's why it is known as juvenile onset diabetes. ठीक है? And it is insulin dependent. Only treatment is insulin. That's why insulin dependent diabetes, and it is only 10% of total diabetes. Type 1. Right, but type 2 is 90%. Majority of the diabetes is type 2, right? It is maturity onset because it is diagnosed after 50 years of age. Usually 40-50 years के बाद होता है diagnosed. And it is non-insulin dependent diabetes. It is a misnomer. ऐसा नहीं है, ये वर्ड पढ़ के आप लोगों को लगेगा कि इसमें इंसुलिन नहीं देते ऐसा नहीं है. We will try with oral hypoglycemic agents first. If it is still not controlled, in the end we will give insulin. So insulin is not the first option. Insulin is the last option. That's why it is known as non-insulin dependent diabetes mellitus. So basically there are 2 types of diabetes, type 1 and type 2. Give me a thumbs up. What is type 1? What is type 1? Type 1 is known as juvenile onset diabetes. This is known as maturity onset diabetes. Type 1 is known as insulin dependent diabetes mellitus. Type 2 is known as non-insulin dependent diabetes mellitus. IDDM and IDDM, GOD, MOD. This one is 10%, this one is 90%. The concept should be crystal clear. आगे बढ़े? Do you have any doubt? Shall I proceed ahead? Right. Now, before starting the various artificial preparations of insulin available in the market, you should know the insulin regulation. Again, physiology portion. The normal insulin regulation. Do you know how insulin is synthesized? Okay, tell me where it is synthesized. Osama, Sachin, where it is synthesized? Tell me where insulin is synthesized in human body. Okay, you should tell me, ma'am, it is synthesized in pancreas. In which cell of pancreas? It is synthesized inside beta cell of pancreas. So can you tell me the steps? How does it synthesized? Yes, Osama. So how does it synthesized? So in the pancreas, inside the beta cell, can you see this is the beta cell? Inside the pancreas, inside the beta cell of the pancreas, this is a beta cell of pancreas. I have drawn one of them. Now imagine this cell is inside the beta cell of the pancreas, right? Now, how insulin is synthesized? First, a pre-pro insulin is formed. Pre-pro. Then it will convert into pro-insulin. And then it will convert into insulin and released in the blood. So what is the difference between pre-pro insulin, then pro-insulin, and then insulin? What is the difference? Basically, can you see the diagram clearly? In pre-pro insulin, we are having 4 parts. Alpha chain, beta chain. Between alpha and beta, there is a connector. The connector is the C peptide. C for connector. Right? And the 4th is signal peptide on the amino terminal. These 4 things. What are the 4 things? Alpha, beta, connecting between the 2 is connector, and signal peptide on the amino terminal. If you remove the signal peptide को remove कर दो, you will remain with 3. Alpha, beta connecting the 2 is C. Right? So these 3 will known as proinsulin. So पहले pre-pro बनेगा, उसमें से you will remove the signal terminal. It will get converted to proinsulin. You got my point? And now you remove the connector also. Then ultimately insulin is formed. So this is how insulin is synthesized. First pre-proinsulin, then proinsulin, and then ultimately insulin is formed. So finally the insulin have only 2 chains, the alpha and beta. Right? The alpha chain has 21 amino acids and beta have 30. So total 51 amino acids. So alpha, this one is alpha and this one is beta. Alpha and beta. Alpha have 21, this have 30. Total 51 amino acid. This is insulin. You have studied all these things in your physiology. Anyways, this is the synthesis. You can see the diagram here. Image based question can come in your exam. You can see what is this? You can see the 4 colors in this diagram. Can you appreciate the 4 colors? Can you see pink color is alpha, blue color is beta. Between them there is a connector, the green connector, C connector. And there is an amino terminal, the orange color. Now you remove the amino terminal. Can you see this orange thing is removed? And you are left with the 3 things. The alpha, beta and the connector. So this one is proinsulin which got converted to proinsulin. Now you remove connector also. This connector is also separated. You are left with alpha beta. So finally this is insulin. So you can, any of this diagram can come in the form of the image based question and they will be asking you, is it a pre-proinsulin? Is it a proinsulin? Is it an insulin? You got my point? Give me a thumbs up if you got it. Give me a thumbs up. So this is how it is synthesized. The same diagram, right? Here also you can see diagram from KDT. You can see this is beta chain starting from amino acid 1 till 30. Can you see 1 and 30? Appreciate the number 1 and 30, right? Can you see this is the alpha chain starting from 1 to 21. Appreciate the number 1 and 21. Can you appreciate the connector between the 2? This is connector. This is connector. Sachin, you got it? Yogita, Usama, you got it? Right? So can I proceed ahead? Molecular weight of insulin is 6,000. 6,000. You have to learn that. Right? Now, okay, let me proceed ahead. We are done with the insulin synthesis. Now I'm coming on insulin released. How it is insulin is released. So yesterday also I told you this story. Insulin will be released when there is a trigger to release the insulin. So whenever any person take a meal, the glucose is going inside. The person is eating. So the carbohydrate glucose is going in the GIT. From the intestine, when the glucose is absorbed and reach in the blood, so when the blood glucose concentration more than 70 milligram per deciliter, that will go to the pancreas, the beta cell of the pancreas. And the glucose enter inside the beta cell of the pancreas and causes the release of the insulin. How does it causes? I have explained to you yesterday the complete mechanism. You were there in the last class. If you were not there, you must watch the recording. Right? Give me a minute. So this is how insulin is secreted in human body. Give me just 1 minute. Okay. Now after that, coming on the insulin action. That also I have discussed yesterday. Synthesis ho gaya, release ho gaya, action ho gaya. Once coming in the blood, can you see the blue dot are the insulin? The insulin will form the door on 3 organs for the glucose. If glucose directly try to enter in these 3 organs, that is liver, skeletal muscle and adipose tissue, glucose cannot enter. Because for the entry of glucose into these 3 organs, a transporter is required. The name of the transporter is GLUT4. But GLUT4 is absent currently. So first insulin come. It will increase the synthesis of GLUT4 and transport the GLUT4 on the cell membrane. Then glucose can enter inside these 3 organs and get stored. So this is how normal insulin act in these 3 organs. Yesterday I have explained you this diagram. Give me a thumbs up. So inside the liver, the glucose is stored as glycogen. Inside the skeletal muscle also the glucose is stored as glycogen, and inside the adipose tissue the glucose is stored as a fat or adipose tissue. So this is how glucose is stored inside the 3 organs. Now the last thing, you already know the pathogenesis of type 1 and type 2. In type 1 diabetes, the body cannot synthesize insulin because the beta cells are destroyed. Who destroys the beta cell? The body T lymphocyte. We all have T lymphocyte inside us, but normal T lymphocyte kills the foreign material, foreign bodies, not the cell. But sometimes these T lymphocyte become self-reactive and they start killing the beta cell of the pancreas. So all the beta cells are killed. A stage will come when zero beta cell, zero insulin. So it is full-flashed type 1 diabetes. What is the treatment? Only treatment is insulin. That I will teach you the various preparation. You have to give insulin because body is not synthesizing natural insulin. You have to give artificial insulin from outside. because body is having zero natural insulin. So you have to give artificial insulin from outside. You got my point? So that is type 1 diabetes. It is an autoimmune disorder. Can you see? So here I have drawn the diagram for you. If you can appreciate, these are the cytotoxic T cell which become self-reactive and they will start killing the beta cells. You got my point? So they are killing the beta cells and the beta cells will be depleted in the pancreas, right? So the B lymphocytes will become autoreactive. The CD4 T lymphocytes, they will kill the beta cells and beta cell will become zero. So no beta cell, no insulin, it will lead to hyperglycemia. Give me a thumbs up. Give me a thumbs up. Yes, due to self-tolerance. So that you can understand. But in type 2 diabetes, insulin is present. The beta cells are present, insulin is present in adequate amount, but it is non-functional. It is non-functional. It cannot react with its receptor. So can you see the insulin is present in the blood, but it cannot react with its receptor and show the action on the 3 target organ. So this is known as insulin resistance. The insulin is resistant now. You got my point? It is present, but it is resistant, it is non-responding. So that is the mechanism of action or the pathogenesis of the 2 type of diabetes. We have understood that. Now let's start the insulin preparations, right? So give me a minute. Let me start the various types of insulin preparations for you. So this portion is from pathology, that's why I'm skipping it. Okay. So let me start the various type of artificial insulin preparations available in the market. How many type of insulin preparations available in the market? The main chapter I am starting now. So there are 4 type of preparations available. Conventional, which are not used nowadays. Number 2, highly purified or monocomponent. Of course, they are also not used nowadays. Human insulins are used nowadays. And the 4th one, insulin analogs are used nowadays. So conventional का मतलब क्या होता है? The conventional one are the prepared from animals. Which animals? Either from the cow, that is beef. Cow या beef, one and the same thing. Or from the pig or pork, one and the same thing. So we take an animal. This is an animal. Either it is a cow or a pig, whatever. So from the animal, we take the pancreas of the animal. From the pancreas of the animal, we take the beta cell out. And we take the insulin of this animal out, right? And this insulin we will pack and use in the humans. But this is highly antigenic, right? So it is having various antigens which are foreign for the human. So it is not at all recommended. और सबसे पहले market में ये आए थे, but nowadays they are not at all available because they are highly antigenic. You got my point? So what are the first one? The conventional insulin, they are prepared from the beef and the pork. You got my point? They are highly antigenic. So you should ask me a question. You should ask me a question that beef and pork insulin, does they differ from human insulin or same from human insulin? You tell me human insulin में कितने chain होते हैं? Human insulin have 2 chain, alpha and beta. Alpha have 21 amino acid and beta have 30 amino acid, total 51. So the beef and pork, the beef that is cow and pork that is pig, they also have this distribution. They also have insulin with alpha and beta chain with the same number of amino acid. But some amino acid differs. Total amino acid 51 ही है, whether it is human, whether it is beef, whether it is pork. The first thing you must understand. Sachin, the antigenic means the which is not self. If this, I'm telling you now, if this insulin is exactly same as that of human, it is non-antigenic. But there are some differences, minute differences in them, although very minute, but they are different from the normal human insulin. So body will not consider this insulin as a self. The body will consider it as a foreign and form antibodies against that insulin. That is the meaning of antigenicity. You got it, Sachin? So what is the difference then? What is the difference between beef, pork and human? So let's see the 3 column. Can you see the 3 column? So see human insulin have alpha chain and beta chain, right? Alpha chain have total 21 amino acids and beta have 30 amino acid. So in alpha chain, I am interested at amino acid number 8 and 10. Total 21 में से सिर्फ ये 2 अलग हैं, है ना? Only these 2 differs in beef and pork. Apart from this, remaining all amino acids are same in alpha. Right, in alpha total 21 are there. The 8th and the 10th are differing. And in beta, out of total 30 amino acid, only the last one, the 30th one is differing. Otherwise, remaining other 29 amino acids are same as that of human. So you have to learn the difference. So in human, in alpha chain, let's talk about alpha. At the 8th amino acid, it's threonine and isoleucine. But in pork also it is threonine and isoleucine. Pork mein there is no difference in alpha. But in beef, it is instead of threonine, it is alanine, and instead of isoleucine, it is valine. I know the things are difficult, but you never know. It's pick up MCQ. So which amino acid is differing at which position? That's about alpha, right? Coming on beta. In beta at the 30th amino acid, normally we all have threonine, right? But in beef and pork, we don't have threonine. Instead of threonine in both of them, we have alanine. So beta is differing in both of them, but alpha is differing. So can you see the pork is differing only in one amino acid, the beta one, beta chain, and beef is differing in all three. You got my point? So who is more close to human? Who is more close to human? Human के ज़्यादा close कौन है? Human के ज़्यादा close insulin is pork or beef? Who is more close to the human? More close means less differ. So pork is differing only in one amino acid and beef is differing in 3 amino acid. You got my point? Pork is differing only in beta chain, the 30th amino acid, that's it. But the beef one is differing in beta chain 30th तो है ही है, beta chain 30th amino acid, but alpha chain 8th and 10th also, they are differing. And what is the exact difference? You must learn it. So who is more close? Who is more close? Sachin, yes, the pork is more close. Of course, we all can see it. So this is an MCQ. This is an MCQ in your PYQs. It is an MCQ of FMGE. So among the two, who is more close? Or both are equal? No, both are not equal. You should know why it is there. So that's why both are antigenic. But you can say pork is less antigenic and beef is more antigenic, right? So the same thing is written in front of you. You can appreciate it. So beef differs by 3 amino acid. You know what 3? And pork differ only in 1 amino acid. So that is about the beef and pork, but these are no longer used nowadays because of the antigenicity. They have many side effects. We don't use them, right? So after the conventional, we have prepared in that era, in the past, we have prepared highly purified. So they are conventional only, the only thing we are purifying them before injecting. जो conventional है वो animal से निकाल के without purification directly injected to human. So it is highly antigenic, you know, because apart from insulin, some other impurities are also there. But here we are first purifying it, removing the impurities and then injecting. Still, it is antigenic. Still, the less antigenic than conventional, but antigenic, that's why not used nowadays, right? So we do the purification and then inject, but still not used nowadays, right? The third are the human insulin. Then we have realized कि ये भी काम की नहीं है, ये भी काम की नहीं है. So why not to prepare the insulin from humans only? Why to prepare from the animals? So we try to prepare the insulin from the humans. How can we prepare the insulin from the humans? Humans में से हम कैसे prepare कर सकते हैं? How can we prepare? So this is a healthy individual. This is a healthy human being. See how I will prepare the artificial insulin from natural insulin. So this is the pancreas of this human. Inside the pancreas, this is the beta cell. So let me draw a beta cell, a zoom version. So this is the beta cell. This is the nucleus of the beta cell. Right, inside the nucleus of the beta cell, these are the chromosomes, 23 pairs of chromosome. Right, now inside the beta cell, as you told ki ma'am, insulin is synthesized inside the beta cell. So this is insulin, the natural insulin inside human. But for every, insulin is a protein. You know, insulin is a protein. For every protein there is a gene. So what is the gene of insulin? Where it is located? So the gene is present in the nucleus. So take out that gene. Take out that gene. So you take the gene of insulin, just cut it and take it out. So take one beta cell, just take the nucleus out, just take the DNA out, and with the help of karyography, then take the chromosomes out from the DNA extraction, then exactly identify the gene of insulin, and with the help of enzyme known as endonuclease that cuts the gene. You cut the gene and take it separately. Now I am having a portion of DNA. This is a portion of DNA. And it contains the gene of insulin, exact gene of insulin. So I'm having this with me. Give me a thumbs up. This technique is known as genetic engineering, what I'm telling you. So first take human, the pancreas, step by step chalo. Take a human, healthy human. Inside the human there is pancreas. Take the pancreas. From the pancreas, consider the beta cell. Take it out. From the beta cell, take the nucleus of the beta cell. Inside the nucleus, take the DNA out. From the DNA, take the chromosome. From the chromosome, take the gene, the exact gene of the insulin. Give me a thumbs up on this point. You got it? Yes or no? So we are taking the gene out. Now we are having this gene. Now what we will do? We will select a vector, you know, vehicle. We will attach this gene with a plasmid or with some vehicle, plasmid or a vehicle, and insert this gene into a bacteria like E. coli. Now this is a bacteria, E. coli. We are inserting this gene with the help of vehicle inside the E. coli. This is the nucleus of the E. coli, right? Now when this gene will be inserted, the human gene, the insulin gene is inserted inside the E. coli. So this is the DNA of the E. coli, and in this DNA the human gene is also integrated. So now this E. coli have its own DNA and integrated the gene, the human DNA. right? So integration occurred. Now whenever this E. coli will divide, you know, E. coli divide every 20 minutes. So whenever it will divide, it will form synthesis. Now this E. coli will start forming insulin because it is having a gene for insulin. So all the E. coli which it is dividing, everyone will form insulin and we will extract that insulin. Now this insulin is exactly same as that of human because we are preparing it from the human gene. So it is not at all antigenic. The exact 51, that is 21 plus 30 amino acid alpha and beta, exactly same, not at all antigenic. The technique is known as genetic engineering. Give me a thumbs up, come on. So this is how we have prepared human insulin with the help of DNA technology using E. coli or yeast. We can insert it inside the E. coli or yeast. The technique is shown in front of you. The technique is known as genetic engineering. You have studied the steps of genetic engineering in microbiology, I guess, yes or no? So here, can you see here, I am having DNA. Inside the DNA, can you see this gene, small gene? So first I will use an enzyme restricted endonuclease, which is the scissor, the genetic scissor, that will cut a gene, exact gene of insulin. After that I will take a vector. The vector is the vehicle, it can be a plasmid. I will bind the vector with the gene, right? So the vector is binded with the gene. And now this is E. coli. Can you see? This is the host cell, E. coli or yeast. I will insert the vector inside it. Now whenever the E. coli will divide, all the cells will have insulin gene and they all will give insulin. They will synthesize insulin, we can extract it. So the same thing is shown here, right? So this is better. The best insulin we are using nowadays is human insulin. These two are banned, not at all used, but human insulins are used. Everyone give me a thumbs up. Sachin, Amir, Osama, anyone else watching me live, give me a thumbs up. Jitne audience utni thumbs up. Shall I proceed ahead? Shall I proceed? ये तो human insulin है, right? But human insulin को भी और better बनाने के लिए we have done some changes in this human insulin, not in animal. Animal वाले तो हम use ही नहीं करते हैं. पुराने ज़माने में use होते थे आज से 50 years back, 100 years back. But they are not used nowadays. They are not at all used nowadays, right? We use human insulin only. So human insulin is exactly same. The same 51 amino acid, the same sequence. But we do a little bit change in them and we are preparing the analogs. The human analogs only for the betterment. उसको और better बनाने के लिए we are doing so. So that is the human analogs, right? Because if we give the natural insulin, there is a risk of hypoglycemia. To reduce that risk, we are doing some changes. What changes I will tell you. So that is the 4 type of insulin, right? So that is the first classification. Conventional, highly purified, human, and analog. Have you got it? What does it mean? Have you got it? What does it mean? Now let's classify human insulin into 4 categories. The human insulin are of 4 types, right? Based on their onset of action. What do you mean by onset? Onset का मतलब क्या होता है? Sachin, what do you mean by onset? Onset of action means whenever you are giving insulin to any human, you are giving the injection of insulin to any human being. After how many minutes or hours, after how much time it shows its action. So that time is known as onset. So based on onset, they are divided into 4 categories. Yes, Sachin. Yes. So it's rapidly acting, it's short acting, intermediate acting, and long. You must mind one thing: rapid and short are different. Students get confused. Rapid अलग है. Rapid को we can say ultra short. Ultra short. So rapid and ultra short is one and the same thing. So ultra short, short, intermediate, long. So you will say, ma'am, what is the time of onset of each of them? So the time of onset of each of them, for the rapid, the time of onset is 10 to 15 minutes. So just after giving injection, within 10 minutes, it will start showing its action. The short acting will show the action after 30 minutes to 1 hour, right? The intermediate one will show action after 1 to 2 hours. And the long acting will show the action after 4 to 6 hours after giving the injection. So this is how you can see based on onset of action. Give me a minute. Based on onset of action, we are dividing the insulin into 4 categories. You got my point? Now let's further divide them. The rapid acting, short acting, intermediate acting, and long acting. Call rapid acting as ultra short. You can call them, right? The rapid acting are further 3 types. The further 3 types. It is lispro, aspart, glucagon. Along the mnemonic lag. Insulin lispro, aspart, and glulicin. Lispro, aspart, and glulicin. If you notice their spelling ना इसमें एक mnemonic है. सब में S आ रहा है. Lispro की spelling में भी S आ रहा है. Aspart की spelling में भी S आ रहा है. और glulicin में भी S. Suspension. Insulin zinc suspension or Lente insulin. The zinc one is the Lente. You got my point? And the second one, instead of zinc, if we add protamine in the regular one, it is known as natural protamine Hedgehog or isophane insulin. So you have to learn all these names, right? Now coming on the long are two. It is Glargine and Detemir. So Glargine और Detemir दोनों में R है. So long acting always contain R, the short acting always contain S. Have you got it? Will you help me in writing the classification once? The classification is ultra important. If you learn the classification, half of the job is done. So tell me the four type of insulin. So you say ultra short, short, intermediate and long. Can you tell me? Ultra short also known as rapid. What is their onset of action? The onset of action of rapid one is 10 to 15 minutes. Here 30 minutes, half hour to 1 hour. Here 1 to 2 hour. Here 4 to 6 hour. That is onset of action, not duration of action. That is onset of action, right? So can you tell me the ultra short? The ultra short are 3. LAG. That is Lispro, Aspart, Glulicin. They all contain S in their spelling. Okay. Short acting is only one. Regular. That's it. Only one regular. So coming on the intermediate. Intermediate are 2. Both of them are prepared from regular, right? So if we add zinc in the regular, or we can add protamine in the regular. We can add two things in the regular. If we add zinc in the regular, it is known as Lente insulin. And if we add protamine in the regular, it is known as NPH, natural protamine Hedgehog, or also known as isophane. You got my point? So that is the two types prepared from the short only. If we add something, they will become intermediate. Now coming on the long one are only two. That is Detemir and Glargine. Don't get confused in Glulicin and Glargine. Both are from G, but here Glulicin contain S and Glargine contain R. Detemir and Glargine both contain R. So based on the spelling, you can learn that. You got my point? Yes, you all are right. Sachin, Amir and Osama. You all are right. Very good. So that is the classification. After the classification, let me start with the regular one. First, I will teach you the short acting. That is regular one. Kahan gaya classification? Yeah, this one. And then I will tell you how short converted to intermediate by adding zinc and protamine into them. In the end, we will see rapid and long. Rapid or long hum end mein dekhenge. So let's see the regular one. Regular one is the short one, right? So it is the insulin which is present at neutral pH, right? It is at neutral pH and it is the regular one. So here a small amount of zinc is present in this insulin. I am saying a small amount of zinc. Let me see here. So can we see here in this diagram? You can see the insulin is along with the zinc. It is given along with the zinc. So here the zinc is forming the hexamer along with the insulin. Can you see here? The zinc is forming the hexamer along with it. So whenever you are giving a subcutaneous injection, this is a subcutaneous injection you are giving, the insulin, the regular insulin. You are giving an injection to your patient with regular insulin, the subcutaneous injection, this is the blood vessel, right? Since it is forming the hexamer, it cannot directly enter into the blood vessel. First from hexamer, it will convert to monomer and after that it will enter the blood. You got my point? The hexamers enter the blood very slowly, the monomers enter the blood very fast. So overall action will become short. It is not ultra short, it is not long, it is short. You got my point? So this is the mechanism of action. This is the mechanism of action, right? But the only disadvantage is that you have to give injection half to 1 hour before the meal. Right. So as I have told you, there are 4 types of insulin. The rapid one, the short one. Currently I am teaching you short one, the regular one. Then intermediate one and long one. So the short one are the one which show mechanism of action half to 1 hour after their administration. So imagine I am the patient. I am a diabetic patient. You are my endocrinologist. You are my doctor. So you are prescribing regular insulin to me. You are prescribing regular insulin to me. Ma'am, you are diabetic and your diabetes is not controlled on OHA. You should start insulin now. So I will ask you, doctor, which insulin should I start? You will say regular insulin. Whatever preparation, the brand name you will tell me, it is a regular insulin. So the next question I will ask, when I should inject it. The injection is only one route, subcutaneous mostly, right? So we are giving it subcutaneously. So we have to give it before meal. So how much time before meal? So you will ask me half to 1 hour, right? So before lunch also, before dinner also, before breakfast also. Half hour before, half hour before, half hour before, or 1 hour before, so that it will show its action maximum. So first I will give, just suppose I want to have breakfast at 8 o'clock. So at 7 o'clock I will give injection and at 8 o'clock I will take my breakfast. Same with lunch, same with dinner. So 1 hour or half hour before I have to give. But it is very difficult, you know. For the patient in such a busy life, it's very difficult. Just suppose I have given a insulin injection at 7 o'clock to myself, and I want the breakfast at 8 o'clock, but between 7 to 8 I got some urgent work, very urgent, I cannot avoid it. So I have taken the injection, but I will miss my meal. So if I have taken the injection and I have missed my meal, I can go in hypoglycemia. Sachin, you were asking now why the insulin causes hypoglycemia. What does insulin do? I have shown you the arrow now. Insulin take the glucose from the blood to the cell. So whatever glucose present in my blood will enter the cell. So my blood will have less glucose, that is known as hypoglycemia. So that can cause hypoglycemia, right? So it is not very useful. Yeah, useful for the person like who are free, not very busy, and they should take it regularly half hour before the meal. But you know, for a very busy person, जिसके पास time नहीं है, that will prefer कि मुझे rapid वाला दो. That I have to take 5 minutes before my meal. Just I will take my injection. The dinner is ready on the dining table. The lunch is ready on the dining table. Meanwhile, I will wash my hands. I will get prepared for the lunch or dinner, and I will start my dinner. So I don't have to wait. I will give the injection. Within 5 minutes, I can start eating. But here, after giving the injection, I have to wait for 1 hour. 1 hour is a big thing, right? I give my injection and wait for 1 hour. Okay, 1 hour will be over. Then I will start eating. It's difficult. Every meal, every day, every time. Right? So rapid are more comfortable as compared to short. You got my point? So how many times you have to give the injection? I'm asking about regular. Currently I'm teaching you the regular one, right? So you have to give the injections 3 times, right? Normal people eat 3 times. So just suppose the breakfast is at 8 o'clock, the lunch is at 2 o'clock, and the dinner is at 8 o'clock. So 8 a.m., 2 p.m. and 8 p.m. The breakfast, the lunch and the dinner. So before, half hour before each of them, you have to give 3 injections. But the 2 disadvantages I have told you. Number 1, 3 injections are required daily. 3 injection is a big thing. Patient को रोज 3 injection लेने पड़ेंगे. And number 2, the patient has to injection 1 hour before each meal. Both things are difficult. So these are the 2 disadvantages. बाकी regular is good and it is commonly used. ठीक है, काफी commonly use करते हैं. Now we converted regular into intermediate, right? Regular में hypoglycemia की risk भी बहुत ज़्यादा है. So to reduce that risk, we convert it into intermediate. The intermediate insulin are 2. We can convert the regular into intermediate by 2 things. Number 1, by adding excess zinc. Regular में small zinc तो होता ही है. If we add excess zinc, it is known as Lente. And if we add protamine, it is known as isophane. So Lente and isophane are the 2 types of intermediate acting. You got my point? So these are the 2 types of intermediate acting. The Lente one and the isophane one. The Lente and the isophane. Right? Now coming on short and long. The ultra short, not short, I'm sorry. The ultra short, the rapid one and the long one. These 2 are insulin analogs, in which we have done a small change to convert the natural insulin into the analogs. Right? So let me tell you, the first one is the insulin Lispro. Lispro से शुरू करते हैं. Short acting से, rapid acting से शुरू करते हैं. Rapid में 3 है. Lispro, Aspart and Glulicin. So Lispro में हमने क्या change किया? Lispro में बीटा चेन पे, बीटा में कितने होते हैं? How many amino acids are there in beta? Total 30. So total 30 में से 28 and 29 पे, normally we are having, at 28 we are having proline, at 29 we are having lysine. We are reversing it. At 28 we are doing the lysine and at 29 we are doing the proline. By doing so, it will become ultra short. Instead of short, it will become ultra short by doing, just reversing the sequence. Give me a thumbs up if you got it. So can you all see this diagram? Sachin, Osama, Amir, can you see this diagram? Let me explain you this diagram. So in this diagram, this is the alpha chain, this is the beta chain. Can you see alpha chain में total 30, okay, just a second. Alpha में total 21 amino acids are there till here, and beta में total 30 are there till here, right? In the beta, I'm interested in beta one. See the beta. Beta में see the last 2, 28 and 29 number. Can you see these two? Zoom it out and see these 2. So normally it is proline followed by lysine, but we are reversing lysine followed by proline. So if we do so, it will convert into Lispro. This is Lispro. So basically in Lispro, we are doing change in beta chain, not in alpha chain. Beta में क्या change कर रहे हैं? At 28 and 29, we all have proline and lysine. But instead of proline and lysine, we are doing lysine and proline. So if we do so, it is known as Lispro. It is no more natural, it is known as Lispro. So that is the Lispro one, right? It will become ultra short. You can immediately give it before the meal, 5 minutes before the meal. Aspart में क्या change कर रहा है? Aspart में also you are doing the change at beta chain. Only beta 28, not 29. At 28, what we have, I have told you it is proline. Instead of proline, you are replacing it with aspartic acid. Proline की जगह aspartic acid कर दिया, तो it is known as aspart. Aspart से याद आएगा aspartic acid. You got my point? So that is the S part, the second one, the S part. And the third one, glulicin, maybe beta chain में ही replace कर रहे हैं at beta 23 and 29. 23 पे lysine is replaced by arginine and 29 पे glutamic acid, lysine is replaced by glutamic acid, right? So you have to learn exact. So let me draw the insulin. This is alpha chain, this is beta chain. Alpha chain have amino acid number 1 till 21. So these are the 21 amino acids in alpha. I am not doing any change in the alpha. I will do the change in beta. Beta have amino acid number 1 till 30. Right. So I will do the change in them. I will do change in 29, change in 28, change in 23. On these changes, I will form 3 type of insulin. What 3 type of insulin? So let me tell you the first one. The first one, at 28 and 29, we are having proline and lysine. If we reverse proline and lysine sequence, it will become Lispro, right? In S part, we are doing change only at 28. Instead of proline, we are replacing it with aspartic acid. That's why known as S part. And in the third one, which is the third one? The third one is the glulicin. We are doing change at 23 and 29. So what exact amino acid we are having there and what is their replacement? Learn that. Learn the number of amino acid. So that is the third one, glulicin. So that is the 3 rapidly acting. You should know in beta change we are doing the changes, not in alpha, and exactly which amino acid and what is replaced by what, and all these to make it ultra short. That is rapidly acting, so more convenient for the patient. Give me a thumbs up. Everyone give me a thumbs up. Have you got it? So here, that is about the rapidly acting. So you got an overview how to read the insulin. The same will occur with the long acting also. Let me tell you long acting also before ending the session. Give me a minute. In the long acting, we are having 2 Glargine and Detemir. So in Glargine, we are doing change in alpha also, beta also. In beta, we are not changing anything. We are not replacing anything. After 30, we are adding 2 additional arginine. So instead of 30, there will be 32 amino acid in beta. And in alpha, we are replacing at alpha ka 21. We are replacing arginine, aspargine with glycine. So we are doing change in alpha also, beta also, and that makes Glargine. And the last one will be Detemir, right? In the Detemir, we are doing change again in beta. In the beta, B29, we are at B29, we are adding 2 additional fatty acid, not amino acid, that is known as myristor. So my suggestion to you, write the 3 name of rapid and write the 2 name of long acting. What are the 3 names first? The 3 names are Lispro, Aspart and Glulicin, and here Glargine and Detemir. My advice for all of you to make a table, right? Whether the change is in alpha or beta, right? Whether in which of them the change is in alpha or beta. What is the exact change? Write down and make a table. Like just for example, in Lispro that there is no change in alpha. Yeah, there is no change in alpha. But change in beta. Beta mein kahan pe? It's 28 and 29. So what is the change, right? That also described. So instead of proline and Lispro, it's Lispro and proline. So like that. So for everything, here also the change is in beta only. But in long acting, the change in alpha also, beta also. So you have to describe the exact change, what we are changing in alpha or beta, at which amino acid, what is replacing what. So it will make a table, and you can't imagine इसपे कितने MCQs हैं और कितने create हो सकते हैं. So that's all about it. Everyone give me a thumbs up. Everyone give me a thumbs up, everyone. So just a second. So here I would like to stop with the insulin preparations. The various type of preparations of the insulin are there. So rest I will continue in the next session. So thank you very much. If you still have any doubt, please leave a message on this contact number, that's 9833032948. Either leave a message on Telegram or on WhatsApp. Don't forget to tell me your college name, university, exam dates if you have not yet told me. So I'm going to send you a list of important topics which are important for pursue your university exams. So don't forget to tell me that. Thank you very much. Study hard. All the best, and thank you for giving your precious time to me. And tomorrow we are going with the next important topic from microbiology. So next 2 days I'm going to teach you important topics from the microbiology. Thank you. See you. Bye bye. Study hard. All the best.